Hi, this is Dr. Bernstein with our September 2021, hopefully thrilling episode of Dr. Bernstein's Diabetes University. We're going to go over some special subjects and then I'm going to be answering questions. There are a number of articles that came out in the past month or so that I should discuss, and the first one points out a study with metformin and cultured rat pancreatic cells from embryo cells from rat fetuses, and basically exposing the rat's fetal cells, fetal beta cells, to metformin resulted in impairment of their growth and differentiation. Now, these are rats, these are not humans, and this was in a culture medium, not in living rats, but still, the implication to me is that maybe metformin should not be used in pregnant women. Up to this point, I believe pregnant women who are taking metformin have been advised to continue it. Now here is the first article I've seen that shows the potential for adverse effects of metformin during pregnancy. Now remember, this is rats and this is in a culture medium. This is not living rats, but it's something to think about. Now, there have been a couple of recent articles that even hit the public literature about the values of exercise. Over the years, there have been a number of articles pointing out that exercise in older people enhances memory or inhibits deterioration of memory. And now a mechanism apparently has been elucidated on how exercise may affect memory, and it appears in a recent issue of the New York Times. And apparently, exercising muscles produce certain chemicals that enhance memory, and they've identified the chemicals, which are things I've never heard of. So we now have a physiologic reason why exercise can help memory. Another one is a large study. I think it was more than 5,000 people, and it was performed in Europe, and recently reported that there's a significant reduction in death rate. I believe it was something like a 25% reduction in over a long-term period of time. I think they watched diabetics over the course of 15 years, and the death rate was reduced by approximately 25% in those who cycled. Now, I don't recall from the article whether they were stationary cycling or outdoor cycling, but again, more advantage to exercise. Now, this does not, although this was done in older people, that does not mean that if you've never exercised or never biked, you should all of a sudden start biking and do it in an extreme way, because you could kill yourself that way. So, and by the way, when I start a person on cardiovascular exercise, which may include biking, I usually get a coronary artery calcium score and also an exercise stress test to see if the EKG is adversely affected by exercise. There has been a lot of publicity over new products. I think one or two companies are selling glucagon kits, easily injectable glucagon, like push button injection, for kids to carry around, especially when they're exercising. In case their blood sugar drops, they're supposed to take a shot of glucagon. Now, this is a potential real problem because for several reasons. One reason, of course, is the cost. I don't know the cost of this, but glucagon is a very expensive product. And it's probably many, many times more expensive than liquid glucose, which I always have handy. And I measure it in a shot glass. These kids can carry around a little plastic container that squeezes out a certain amount, or they can estimate the amount from the one capful from the bottle of liquid glucose is the amount that's in a teaspoon, and you can calculate with the information on the bottle how many grams of glucose are in one cap. It's approximately a gram, as a matter of fact. So one capful gives you a gram of glucose. And if you know how much 1 gram raises a kid's blood sugar, you're going to get much more predictable blood sugar results at a small fraction of the cost and without an injection. So I wouldn't go spending money on injectable glucagon for kids to carry around. Now, if you want to use it for someone who's unconscious, that's another story. And that's another subject which I'm not going to talk about now because I've already discussed it. Well, this is an article from the journal Science, and it studied toxic effects of very high fat diets where the subjects were using, I think, vegetable oil, and apparently there are complicated toxic effects of super high fat diets, which I should point out are equivalent to these keto diets that you hear about lately. As you know, there are many purveyors of foods and supplements who are trying to make money selling what they call keto diets, and they recommend drinking vegetable oil, drinking olive oil, etc., etc. And apparently there are potential consequences. It's in a recent issue of the journal Science. So just reiterates what I keep saying. My main objection to these high-fat diets is that they tend to reduce the protein intake which is nutritionally necessary for most humans. Well, this is one of many articles published in a publication of the American Diabetes Association. This was a large-scale study of long-term survival of people with, I believe, type 1 diabetes, and they state in their conclusion that optimal glycemic control remains central to prevention of cardiovascular disease and survival in type 1 diabetes. Well, here you have an opinion being stated that blood sugar control is essential, and they're advocating, as you know, high blood sugars by virtue of their high guidelines for the hemoglobin A1C. One last thing that many people are going to hear about and ask about and wonder about is FDA panel supports islet cell treatment for type 1 diabetes. A medical panel by a small margin approved islet cell transplants with immunosuppression for the treatment of type 1 diabetes. And they say it's for selected individuals whose diabetes blood sugar variability does not respond to conventional treatment. Well, conventional treatment is going to cause a wide variation in blood sugars. So in theory, this would apply to most type 1 diabetics who are treated by conventional methods with high carbohydrate diets, high doses of insulin, and all the unpredictability that goes with it. As far as I'm concerned, if islet cell transplants worked, and right now the evidence is that we don't know if it works, you still have a patient who's immunosuppressed. In order not to reject these islets, you have to put him on immunosuppressant drugs that expose him to both infectious diseases and malignancies. And I can speak firsthand that it's not a desirable situation because I have type 1 diabetes and I also have common variable immune deficiency. In fact, I was about 11 years old when I developed type 1 diabetes, but I was born with immune deficiency. And it's not easy to treat, and it's although at the very beginning, when we didn't have the tools we have for diabetes, the diabetes was more painful than the immune deficiency. Today, the immune deficiency is more painful than the diabetes. I have to get infusions every 3 weeks that take half a day, and the intravenous connection is not easy because my veins have been so damaged by thousands and thousands of venipunctures. So it's not easy connect me to the infusion. Kind of torture. Now we have on the subject, one more interesting event. I was, as you know, in the northeastern part of the country, we're beginning to get some of the bizarre weather that they're having in other parts of the country. And we have had power outages, and I have a patient who fortunately had a generator for her home, but her power went off for 6 hours before her generator kicked in. So it's, even though you have a generator, you may have power problems. And she kept all her insulin in a particular refrigerator and was just about to throw it all out when she spoke to me on the phone for a routine follow-up call. And I said, don't throw it out. 6 hours at room temperature, or in her case, the temperature was around 80 degrees for part of that time, is very unlikely to destroy your insulin. So save your insulin and try it out. If you find that it's not working, whichever vials are not working, you throw out. But don't just assume that 6 hours exposed to 80 degrees Fahrenheit is going to destroy your insulin. And you might do one other thing, which I do, which is a safety against power failures. And that is to keep your insulin in the refrigerator in a Frio bag. Here's a Frio bag. They make bigger ones than this. I think they make one that's twice as big as this. And you could, if you have many bottles of insulin, you could buy several Frio bags. I have several bottles of insulin in here, and I keep it in the refrigerator. And if we do have a generator, and our generator always kicks in, but the time may come when it doesn't. Well, I have a backup because it's in the Frio. So the backup for power failures is not just the generator, but keep your insulin in a Frio bag in the refrigerator, and the Frio is going to keep it at a cool temperature even after the refrigerator shuts off. One more little problem that I discovered since the last video, and I discovered it on myself. I found that I was getting high blood sugars out of the blue that I couldn't explain. And finally figured it out. It has to do with not getting enough insulin into your syringe. Now, how could that happen? You pull the plunger out, you set it at the dose, and it says that you have a certain amount of insulin. Well, I noticed that a couple of the shots that I gave, when I pushed the plunger, there was no resistance, as if I was pushing out air. So I gave my shot, and it felt like I was injecting air. So after that, I decided to do a test before each shot. I'd pull in excess insulin, and holding the syringe vertically, needle pointing upward, I'd squirt some insulin against the palm of my other hand. And why did I have it pointed upward? Because if there was air in the syringe, the air would be upward. It would be at the top in the direction of the needle. So I'd push, and if my hand got wet and I felt the liquid hitting my hand, I know that I got insulin. Well, some of the time I'd feel the insulin against my hand, and some of the time I'd push slowly, and I'd first feel nothing, and then I'd feel the insulin. So I discovered that it's possible to set your dose, and half of it is air and half of it is insulin, or a quarter of it is air and 3/4 is insulin. I never realized this before. Why on earth would that happen? And I then made a discovery that I started injecting air into a particular vial that was telling me it was not getting any insulin. Remember that when you fill a syringe, you're supposed to inject air into the bottle in the amount that you're going to amount of insulin that you're going to pull out. If you're going to pull out 3 units of insulin, you inject 3 units of air. Well, that's sort of trivial, but if you're going to do 10 units of insulin, 10 units of air, in theory, that 10 units won't make much of a difference. But over the course of 10 days, that's 100 units, which is a whole cc, which is 1/10 of a vial of insulin. And if you have a cc of vacuum in your vial, it's going to inhibit the amount of insulin you could pull out. So what I now do is I take a syringe that I call my air syringe, and I've marked it with a felt tip marker so that it's blue. Could have been black or green, but I marked it so that it's blue. And what I do is every few days, maybe once a week, depends how much insulin you're using, I take the plunger out, stick the needle in the middle of the stopper and the cap of a vial of insulin, and if there's any vacuum in my bottle, in my vial, it's going to suck new air in through the needle. I've taken the plunger out, so it'll restore normal air pressure into the vial. And you do this every few days, and you'll keep your vials adequately charged with air. So I'd say that if you're taking tiny doses of insulin like I do, maybe once a week is enough. If you're taking ADA doses of insulin, you could do this every day. So this is an important tip. I think everyone should follow it. And this Frio bag with 2 other Frio bags that I have in my refrigerator is going back to the refrigerator. Now we have our questions, but before we answer any questions, I remind you that my answers are guesses. They have to be guesses because I've not examined the questioner or the patient that the questioner refers to. I've not gotten a full history, not gotten a family history, not gotten a whole list of medications and supplements. So to give medical advice without that information, all it is a guess, and it may be totally wrong. But the intent of this video series is to educate the viewers, and hopefully each answer will be educational, even though it doesn't really take care of the problem of the questioner. So you should always go check with your doctor if I give you an answer. It may be totally wrong. Type 1 diabetic, constant blood sugars 80 to 90 milligrams per deciliter. A1C at 4.8, thanks to your book. That's my book. Triglycerides are 170 milligrams per deciliter. The maximum at lab is 150. Apoprotein B is 1.48, which is at the maximum at lab is 1.4. And are the lipids and blood issues related, and will statins solve the problem? Well, it's been discovered that statins, for many people, actually save lives, prevent heart attacks, and their main mode of action, although they may lower VLDL, for example, and I might add they do not lower triglycerides. Triglycerides relate to blood sugar and very possibly to the amount of carbohydrate you had in the last meal. Statins are effective at reducing inflammation, and most vascular diseases are related to inflammation. They reflect inflammatory processes, and part of the Framingham study disclosed that statins actually were saving lives, but not in relation to the effect upon LDL or VLDL, etc., but rather in relation to the effect upon inflammation. One test for inflammation is C-reactive protein. Another thing is that some of the tests, in particular triglyceride, is usually measured in a fasting state because the value can relate to what you last ate. I try to follow your recommendations. I eat basically the same. Recently my A1C went from 5.5 to 6.1. I eat basically the same and would appreciate your ideas of what I might try to bring it down again. Well, that's a tough one because we don't have much information. Infection will raise your blood sugar and raise your A1C, and the one source of infection that tends to be occult in many people is infections in the mouth and the teeth, root canal, gums, etc. Another reason why the A1C could change would be a change to a different laboratory. The laboratories use kits for their various tests. The kits are a set of reagents and a set of instructions on how to use the reagents and what equipment to use. And these kits get changed from time to time, or the supplier of the kit gets changed, or you go to a different lab, and the A1Cs are different in that lab from the old lab. Another possibility is that you're using an insulin pen, and we know that the insulin pens tend to leak and give different doses every time you give a shot. Another possibility is the one that I mentioned today, where there's not enough air pressure in your vial of insulin and you're using a syringe, and you're not getting a full dose of insulin in your syringe when you draw it out of the vial. Another possibility is spoiled insulin. You could have had a power failure and not kept your insulin in a Frio bag in the refrigerator, and the insulin could have been at an elevated temperature for a week or a couple of weeks. Or you may have gained some weight, causing insulin resistance. So there are many, many things that can cause your A1C to go up. Is it possible that I am having some type of allergic reaction to Tresiba? I am also experiencing urticaria, that's rash, since commencement of this long-acting insulin. Well, I don't know what your symptoms are. Well, you do say you have a rash, and if it's started after you started taking the Tresiba, there's a good possibility. So how do you find out? You switch, say, to Levemir. Probably the dosage will be about the same, but I can't guarantee it. And if you're taking a Tresiba twice a day, you try the Levemir at the same times. And I would give it 2 weeks on the Levemir and see what happens to the rash. Then I'd go back to the Tresiba and see if the rash comes back. And if the rash comes back, you're allergic to Tresiba. Now, in the old days, there used to be ways of desensitizing people to insulins to which they were allergic. And in the old days, we had diluents for the insulins. For Tresiba, I know of no diluent. You could check with the medical department at Tresiba to see if there's something that can be used for desensitizing, is the technique that a doctor can use, where you start off with a very, very dilute solution of the insulin. You inject it intradermally, you look for a reaction, and maybe an hour or two later, you make a 10-fold reduction in the dilution. So you might initially have a dilution of 100,000 to 1. Then you go to 10,000 to 1. Then you go to 1,000 to 1, etc. And eventually you inject a small amount of the pure insulin. And if you don't get any reaction, you've desensitized the patient. And in the old days, when we did have diluents, I indeed had a few patients who were allergic to insulins, and I desensitized them. Okay, when the husband had his last 2 bike rides, he started needing to walk his bike because he was getting out of breath and had weakness in his legs. Could this be related to his body not being used to lower blood sugar? He also has severe asthma, but he was never this weak before riding his bike. Well, first of all, he should check his blood sugar when he has these episodes. It could well be that he has a low blood sugar, and it could be, I haven't mentioned what his blood sugar was when he got off the bike. It could have been very low. So it's not just a matter of being lower than it was. Let's say it was previously 150 and now it's 120. I doubt that would make him very weak. But if it was 150 and now it's 60 or 50, I could understand it. So check his blood sugar. There are other possibilities. He could have poor circulation in his legs, and he should see his doctor. He should tell his doctor about this. The doctor can send him to a vascular specialist who may want to do what's called an ankle brachial index determination, which is to measure the blood pressure in the ankle and in the arm, and you take a ratio. And you do that in the resting state, and then you exercise the ankle by having the patient flex it back and forth against resistance. The resistance could be the examiner's hand, and he does this for 30 seconds and again checks the pressure in the ankle, and if there's a major decline, it indicates poor circulation. Another possibility is that he has exercise-induced asthma. I had exercise-induced asthma for many years, and finally got over it. But and my son had it also. So it's and it can be very severe. So if he had trouble breathing and trouble oxygenating his blood, his legs could have felt weak too. So there are a lot of possibilities, and he certainly should see a physician, and he might have to see several physicians, an asthma doctor, a cardiologist, and a peripheral vascular specialist. I recently discovered Dr. Bernstein's YouTube video on CVID, that's common variable immune deficiency, on CVID and diabetes, and it explains so much to me. I have both type 1 and CVID, that's like me, and would really like to consult with and learn from and or become a patient of Dr. Bernstein. How is this possible? Well, if you read my book very carefully, you'll find buried in the book a way to get my phone number. So, and I won't treat any people who have not read the whole book. So if you read the whole book, you'll find out how you can reach me. I'm a type 1 diabetic following your diet. I had A1C below 4.8 since implementing the very low carbohydrate diet. I've been hypertense since I was 16 years old, taking an ARB, that's an angiotensin receptor blocker. That's for the high blood pressure, but it's also for kidney disease. My renin levels are more than 3 times the maximum normal. Is there a correlation between diabetic kidney disease and increased renin levels? Well, it could be, but an increased renin level on its own can be worked up. You probably should see, well, let me read the rest. Some obscure articles state that increased renin levels are roughly correlated with microvascular disease and diabetic complications. Well, that may be true, but correlation does not mean causation. For example, there are many articles that say that eye disease in diabetics are correlated, eye diseases are correlated with neuropathy, with nerve disease. Well, sure, high blood sugars cause the eye disease and high blood sugars cause nerve disease. I doubt that the eye disease is causing the nerve disease. Now, you probably should see a nephrologist, a kidney doctor, and before seeing him, it would make his initial job a little easier if you get a 24-hour protein plus 24-hour aldosterone, and 24-hour albumin, and certainly see a kidney doctor. By the way, when I say 24-hour, I mean 24-hour urine. You have to make the collection and you have to do it in the right way, which the lab will tell you. My book also tells you. Type 1 diabetic child, slightly hypothyroid, following your diet completely. Would you recommend to reduce the dairy intake, fat cheese, fat cream, etc.? I have no idea why. I have no idea why. I assume that this person has been told by someone that dairy causes hypothyroidism, but I don't think there's any relationship. And unless something else is going on, like a lactose allergy or something like that, I see no reason to stop the dairy. I don't smoke. I chew nicotine gum to help me concentrate and give me a boost when I am feeling weary. It has the side effect of also squashing my appetite. I'm wondering if you would recommend this to help people struggling with appetite issues. That's a really good question, and I've been thinking about it since I read it yesterday, and it's substituting one addiction for another, and which addiction is worse. If you're diabetic and say craving carbohydrate and have gotten yourself obese, what's the death rate from the uncontrolled diabetes versus the death rate from nicotine addiction and chronic nicotine poisoning over the years? And I have no idea. I don't know if anyone has done this comparison, and I doubt that it's been done. And I'm sorry that I can't answer it. I think this is the first question that I can't answer today. Time for a drink. Shoot the juice to me loose, cook my goose. Take a quick look at the blood sugar. Okay, 82. Now, where are we? In a recent teleseminar, a girl asked for food ideas for handling Thanksgiving and other holidays with family who did not respect her diet needs. First, never go to a family event hungry. Eat protein before. Now, I'm not saying this. This is what the listener is saying, and I'm passing on the information because some of it may be of value. I don't think I'm doing anything that this listener is recommending myself because I'm not a foodie. I can control myself. I guess I'm fortunate in that I'm not an overeater. So I don't have a problem here. And I'll talk a little about myself when I finish reading what this person is recommending. Eat protein before you go, even if it's in the car before you go, before you walk in the door. The protein cuts down on the cravings a smell might even evoke. Take a dish with you that you can eat. I guess take a product that you can eat. Easy things to take are deviled eggs, pickled eggs, or a cheese selection with olives. Keep cheese sticks in your purse or insulin bag. You can eat cheese sticks as the need arises. Eat a full meal before you go and only put protein portions on your plate. When eating at the table with family, if possible, have the family gathering at your house so that you can control the menu. Have a plan for your insulin dosing if the actual meal time is different than has been stated in the invitation. I hope these ideas will generate other ideas and will help with the holiday meal plans. Well, that's a nice contribution. I was at a holiday party, I think the day before I read this, just a couple of days ago. And it was the owner of the home was a gourmet chef who had he used outside caterers, whom he was supervising very carefully. So the food was, I understand, very delicious and very tempting. And I knew that it would be that way. However, I'm not a foodie. I could control myself. So I had my regular dinner at home a bit earlier than I usually have it, took my usual insulin, didn't have any problems, went to the party, and didn't eat anything. I had some diet soda, and that was about it. I didn't have any wine. I probably could have had a half a glass or a small glass of wine, but I just wasn't taking any chances. And I don't have a craving for alcohol, and I don't have a craving for food, so I'm lucky. I was talking to a diabetic acquaintance a few days ago. When I told her that I used Tresiba, she said that she couldn't because she has thyroid issues. Have you ever heard of this? Are there any issues with Tresiba? None that I know of. I don't know where this comes from. There are warnings about using certain medications for type 2 diabetes other than insulin if you have a family history of a certain type of thyroid cancer. But has nothing to do with any insulins. I am recently diagnosed type 1 diabetes and am working on my menu and dosing. I know about the carbs, but I have a problem with protein calculations for how much of the proteins I should dose for. Well, what you could do, aside from the guideline, first of all, you should read my book, Diabetes Solution, which gives guidelines. But one very good trick would be to eat a meal with only protein. And the time of the day of the meal is going to be, depending which meal you're talking about, your coverage of the protein is going to be different because it can vary with your digestive condition, which could vary with the time of the day. But let's say that you want to know how much insulin to take to cover your breakfast protein. You eat the breakfast protein and let's say take a guess at an insulin dose. Now, in my book, we make recommendations for the guess. And you've taken the guess, you look at your blood sugars over the next, let's say, 6 hours. And if you took too much insulin, you'll be dropping. If you took too little insulin, you'll be going up. So by trial and error, you can adjust the amount of insulin to cover the breakfast protein. Then you could do the same thing on the same day or on another day with the lunch protein. And then you could do the same experiment with the dinner protein. And of course, if you have gastroparesis, all bets are off because the rate of digestion is haphazard, is unpredictable. And again, we have a chapter on gastroparesis in my book. I'm a type 1 diabetic for 22 years. I've been following your advice for 1 year and a half, and A1C dropped from 8.6% to 5.2%. I'm very pleased with the results. What do you think about SGLT2 inhibitors for type 1s on a low-carb diet? Do you think it might be possible to reduce insulin and stabilize my blood sugars with an SGLT2 inhibitor? Even more, or would this be too dangerous because of euglycemic DKA? Well, I'm not concerned with the euglycemic DKA, but I am concerned with the fact that you would have to drink huge amounts of water. And it takes tremendous incentive and self-control to be able to drink the amount of water that you will need to safely take an SGL2 agonist. I do use this product for people who periodically get high blood sugars, such as growing teenagers. When they make growth hormone, and you can't predict when that's going to happen, their blood sugars will suddenly go up, usually at night. And it could go up by 100 overnight or even more. And if you're taking an SGLT2 inhibitor, you're going to right away start putting a lot of that excess glucose into your urine instead of your blood. So it helps reduce the swings, these haphazard, unpredictable swings. But this patient is not having those swings. He's doing pretty well, and there's no reason to take this product. And as I said, it's not the euglycemic DKA, which is a very rare event, but rather the frequent urinary tract infections and other problems stemming from dehydration. So I would stay away from them unless you had a real need. Do you have any thoughts on the Omnipod? I'm 51, type 1, almost 40 years, so this person's a survivor. I have significant retinopathy, gastroparesis, and peripheral neuropathy. My gastroparesis has improved tremendously following a low-carb diet over the past 4 years. I currently take Humulin R, Humalog for corrections, and Levemir. I only take 3 units of Levemir in the morning and 3 before bed. Do you think the Omnipod is a good or bad idea? Well, all the Omnipod is an insulin pump that's reduced in size to a little, what shall I say, something the size of, let's say, a fifth of a hockey puck that you attach to your skin. It has a small cannula that goes into the skin, and it releases insulin according to a program that can be controlled from a cell phone. Well, it also utilizes the same sort of, I shouldn't say fictitious, of phony algorithm that other insulin pumps use, where they pretend that the only food that raises blood sugar is carbohydrate, and pretends that you know exactly how much carbohydrate you're going to eat and so on, and you can set this thing with your cell phone to deliver insulin for your meals as well as basal insulin. And although I haven't seen patients who use the Omnipod, since it's very similar to other insulin pumps, and I've never seen the only well-controlled diabetics I've seen on pumps were newly diagnosed who were making a lot of their own insulin and had to use very little insulin from the pumps. And then what would happen is after a year or so, they develop the scar tissue that the pumps cause, their blood sugars would go haywire. So It just it doesn't make sense. Read my book, and you'll get a lot better blood sugars than you'll get from the Omnipod. Can low blood sugars cause damage too? Several hypos aside, severe hypos aside, can having low blood sugars cause problems like inflammation? The closest thing that I've seen in the way of studies of low blood sugars are the epidemiologic studies of large populations of non-diabetics that seem, and there only have been 2 or 3, as I recall. One was in Ohio, one was in Korea, and I forgot where the third one was. Maybe there were only 2. And they found that a blood sugar, one study was a fasting blood sugar, one study was an A1C. I was looking at A1Cs. There was a J point, and it was around 83 milligrams per deciliter, where blood sugars above that increased mortality, and blood sugars below that increased mortality. These are average blood sugars in the general population going over periods of years. Will blood sugars under 83 increase mortality? Well, maybe if they average, but I can't be sure. And as I said, there's not been real studies. Now, the patients, the reader or the writer says outside of severe hypoglycemia. We do know that severe hypoglycemia can cause convulsions, and the convulsions can cause microhemorrhages in the brain, so can cause brain damage if you get a lot of severe hypos. But he doesn't mention what kind of hypos is he talking about. Is he talking about a blood sugar of 40 or a blood sugar of 70? For kids and pregnant women, blood sugars of 70 would likely be normal. So there's really not enough evidence. Well, that's it for our September 2021 issue of Dr. Bernstein's Diabetes University. Our next episode will be Wednesday, October 27th. From that point thereafter, you'll be able to get another crop of videos. Thanks for watching.